right. Thank you. Let's make sure. Great. Okay. So get started. And so I have obviously no disclosures other than the typical not being an expert, but hopefully did enough research on this and spoke with enough people who are experts to give you an informed discussion around this. Looking at our learning objectives for today. So we want to contrast the physiology of normal QT interval with the pathophysiology of torsades. We'll evaluate the challenges in defining and measuring a normal QT interval. We'll compare the characteristic clinical features of both congenital and acquired long QT syndrome. And then we're going to hopefully grow everyone's clinical comfort level with prolonged QT intervals and develop a at least partially evidence-based strategy for both risk stratification and minimization in long QT syndrome. We will start with a case. And you are the cross-cover resident overnight, and you get the page we are all very familiar with by now. And the question is, what would you like to know or do next? And I will just accept any answers in the chat or out loud about that. So good context clues here. There's obviously a lot of right answers to this, but in the context of this talk, the last EKG is probably the most relevant thing. In general, this may or may not truly be necessary, but for good framing here, we'll say that this is her last EKG, and we'll say that it has a QT interval of 500. And yeah, I'm seeing a lot of answers in the chat that I think are all pretty correct. And we'll talk a little bit more about that. But let's say that you did get that EKG, your QT interval is 500, and what would you do next? All right. Interesting. A lot of practice variation here, which I think is useful to see as we kind of continue with the talk. So we'll chat a little bit more. Yes, Christian, those are always the right choice. Cool. So we'll return to that, but we'll start with a little bit of background on the QT interval. So to remind everyone, the QT interval represents the time delay between ventricular depolarization and then subsequent repolarization of the ventricular myocardium. And we are all very well familiar with it being that green box there on the right, sort of between the start of the first negative deflection there in the QRS interval to the end of the T wave. From an electrophysiology perspective, I'm not going to dive into this too deeply, but if we remember our action potential here, it represents the time between phase 0 or that upstroke and then the end of phase 3 or the downstroke there as averaged across the entire myocardium. And the period there corresponds to the balance between the outflow of potassium and the inflow of calcium, which are two electrolytes that we can think of commonly as causing derangements in the QT interval. So what is a normal QT interval? There's perfect. Great. Okay. Again, a fair bit of variation there, most people favoring the correction. And so we'll talk about that a little bit. So many of you have probably heard sort of the heuristic of less than one half the RR interval. And I think it's important to know that this is only something that you can use in the setting of a normal heart rate. Because if we use this technique, then tachycardia will inherently make the QT interval appear falsely prolonged, and bradycardia makes it appear falsely shortened, as you can see here. And then regarding the question of correction, the QTC, which is what we're all pretty well familiar with, corresponds to the corrected QT interval for heart rate. There's tons of formulas for this. The most popular, most well-known, and probably the easiest is Bezet's formula that some of you may have used before, which uses the uncorrected QT interval over the square root of the RR interval. I think it's important to know that this formula is far from perfect. It's been shown to overestimate QTCs at values at faster heart rates. There are a number of other formulas that have more complexity to them and may be more accurate, but I don't think there's ever been shown, or actually, no, there's no universal gold standard for how we should be calculating this. The difficulty in defining a normal range of QT values, though, results from a lot of variables. There are inherent intra-individual variability in this parameter, which is made more difficult by the limited frequency and timing of actual observations. So there are certain studies that have been done that use Holter monitor recordings that have demonstrated that within individuals, they see ranges as high as 95 milliseconds for their QT interval. This intra-individual variability isn't totally understood, but at least in part, it seems to be related to some diurnal variation, and QTCs tend to be longer in the morning. Additionally, there's a bunch of inter-individual variations, which include things like age. Traditionally, it was called biological sex, but it's becoming more understood to be representative of the sex hormone balance. Generally, we see lengthening leading up to puberty, and then with an increase in female sex hormones, we see prolongation of the QT interval, which has been demonstrated in both cis and trans women on feminizing hormones. And these variations clearly make it difficult to define what a normal QT interval is and then determine the clinical significance of any single measurement in time. So with all of that being said, what exactly is a normal QTC and what do we do about it? So again, no standard definition. If you look this up, you will see a number of different ranges that people consider normal. I think that those listed here in the table, again, are broken out by male and female, but in reality, this is more a distinction that corresponds to sex hormone balance. And I will say that there is a clear difference between prolongation of the QT interval and clinically significant prolongation. In general, I think most clinicians would agree that prolonged QT interval under, say, around 500 milliseconds is relatively rarely clinically significant, but there are practice variations there as well. So I think a more interesting question than necessarily what is normal, but is why do we care about this and when do we care about this? So we'll look at a case, and this is from a case report that I found. And this is a young woman. She has a past medical history of major depressive disorder on fluoxetine. And she presented to the ED with 3 days of intractable nausea and vomiting. She was found to be retching in her room, and she was immediately given a dose of IV ondansetron, 8 milligrams. 15 minutes later, she was still retching, so she had a 10 milligram dose of IV metoclopramide administered. At that time, her labs returned and she had a potassium of 2.6, a magnesium that was less than 1, and her EKG showed this. with a QTC that was notable for a measurement of 680 milliseconds and a short run of polymorphic ventricular tachycardia. She then lost consciousness. They were unable to palpate a pulse, and ACLS was initiated. Simultaneously, electrolytes were depleted. Fortunately, the case had a good outcome, but I think it highlights the importance of this issue that we often don't think about in this amount of detail. I think that as many people alluded to earlier on, you get that page overnight. We'll commonly give somebody a dose of something without thinking about it, which is probably not wrong, but we should at least take into consideration the full clinical picture. So as this case brings up, the relevance of a prolonged QT interval is torsades. And all of you already knew this, but torsades is the polymorphic ventricular tachycardia, in which the QRS morphology and axis go through these cyclical alterations. The universal risk factor is a prolongation of the QT interval. Torsades doesn't exist without a prolonged QT. Most episodes of torsades actually terminate spontaneously, often after just causing syncope, but they can lead to sudden cardiac death. There are studies that have attempted to estimate the incidence of this, which has been estimated to be as high as 4 per 100,000 individuals annually. But even that's actually felt to be an underestimation because of lack of reporting and out-of-hospital deaths. Again, I don't want to dive too deeply into the pathophysiology here, but in the mechanism or the electrophysiology for torsades is that it is a triggered arrhythmia that occurs due to early after depolarizations. So the prolongation of the QT interval results in this derangement in the action potential. So where you had previously seen the smooth downslope there of the action potential, now we have these early after depolarizations. For people who were able to capture this on telemetry, you may see this preceding event of a short, long, short phenomenon, followed by the evolution of the polymorphic ventricular tachycardia. So with all that being said, and now that we're all terrified of that one case in the ED, when exactly do we care about a prolonged QT interval? And this is actually a really interesting and difficult to answer question. I spent a long time looking in the literature for this and talking to a couple of electrophysiologists, and there aren't clear answers as to when we should be concerned. A lot of studies have statements like this, that it is basically this surrogate marker we have that's the best we have, but it's imperfect and we don't really know how to interpret it. I particularly like this one that was published now 25 years ago that calls out the adverse reactions to drug therapy being the bane of the practitioner, and all the more so when they are idiosyncratic or apparently unpredictable. And they mentioned that torsades is the most striking example of this, essentially. So let's see if we can unpack this a little bit and try and come up with a better way of understanding people's risk. I think that the current thinking around risk associated with a prolonged QT interval and the development of torsades is best described using this concept of the repolarization reserve, which postulates that repolarization is modulated by multiple partially redundant mechanisms. And then when one determinant of repolarization is abnormal or inhibited, repolarization perhaps may remain normal or close to normal. However, when we start adding additional perturbations in repolarization, we then may end up with QT prolongation and increasing the risk of torsades. So listed here are a couple of the things that are believed to affect repolarization reserve. QT prolonging drugs are the one we're most familiar with. Underlying cardiac disease, electrolyte abnormalities, similarly, we deal with all the time. And then there's some of the more genetic factors, so ion channel polymorphisms and pharmacogenetics, as well as we mentioned before, sex hormone balance. And then the graphic there is just illustrating a relative blockade of some of these ion channels. And as you increase the blockade, you see you can result in these early after depolarizations that may trigger the arrhythmia. Some of the data we have about risk for prolonged QT and torsades largely comes from populations with congenital or genetic long QT syndromes. So this was one study that looked at adult patients with known mutations associated with long QT, and these Kaplan-Meier curves demonstrate the estimated cumulative probability of any cardiac event, such as syncope, aborted cardiac arrest, or long QT syndrome-related sudden cardiac death. And it was comparing those on the basis of corrected QT interval. And as you can see, those with increasingly prolonged corrected QT intervals were at the greatest risk of cumulative incidence for having a cardiac event. It's obviously hard to extrapolate this to a population who doesn't have known genetic mutations, but it is really the best data we have that suggests that prolonging the QT interval does increase risk for this. From that same study, they then tried to stratify based on the actual degree of prolongation and come up with some sense of what the absolute threshold of risk is for torsades. And it's pretty difficult to say, but the data here suggests that in individuals with a measured QT value exceeding 500 milliseconds was the greatest risk. So 92.2% of all cases in this study of torsades occurred in individuals whose QT was corrected QT was longer than 500 milliseconds. So I think, with these data, we have our best argument to suggest that that is a reasonable threshold at which to be concerned. But again, we are extrapolating from populations who have known genetic defects resulting in long QT syndrome. So a brief review of what we've talked about so far. The QT interval is clearly imperfect. We can calculate it using a number of formulas. Bizet's is probably the most common and easiest for us to remember. Prolonged QTC is the primary risk factor for torsades, and we can try and explain torsades risk via this repolarization reserve concept. The risk clearly scales with increasing QTC, and 500 milliseconds appears to be a reasonable threshold for concern. All right, I was going to pause there for questions. And got a couple other breaks coming up, so just drop anything in the chat too, and I'll get to that later as well. But I was going to jump ahead and talk about how we should actually be measuring the QT interval, which is not actually as straightforward as we would like to think. Great. Nick, excellent question, and we are just about to talk about that. So there's a number of factors that result in challenges in measuring the QT interval. Those range from the very easy to see absences in EKG quality. So when we have a noisy baseline, or the patient's moving or something like that, we may not be able to as easily measure the QTC. Similarly, when we have irregular rhythms or abnormal T-wave morphology, and then the presence of U waves, these all present challenges in how we should measure the QTC. And then there's the less obvious and less easy to quantify differences among and within observers and how they actually measure the interval. So the question often comes up, when can I trust the computer calculation? Or maybe when should I not? And I'll say the answer to this really depends on who you ask. Some people, like some cardiologists and electrophysiologists, would tell you you should never trust it. Broadly speaking, I would say that the more normal the EKG is, the more likely the computer calculation of the QTC is to be correct. but there are a number of circumstances that can result in abnormal or falsely or incorrect calculations. And I would say that if you're ever concerned or having to make an important clinical decision based on the QT interval, it's never a bad idea to manually calculate it. Though when you need a quick safety check, it's not unreasonable to use the computer calculation. But the computer particularly struggles in certain circumstances, such as irregular rhythms, paced rhythms, these abnormal morphologies in the presence of U waves, noisy baselines, and wide QRSs. And then when we tend to drift further from the normal range, so shorter or longer QTs, the computer also struggles. All right. So that said, how is it that you actually manually measure the QT interval? So the first thing is that you should ideally measure it in several successive beats, because any single beat is probably not a perfect capture of what the QT interval is. As we talked about, there's a lot of beat to beat and then over time variation. And you want to identify the beginning of the QRS complex and then the end of the T wave. And for the latter, the maximum slope intercept method, which is illustrated here, defines the end of the T wave as the intercept between the isoelectric line with the tangent drawn through the maximum downslope of the T wave. So as you can see here in these examples, we are not necessarily tracing the end of the T wave to where it actually meets the isoelectric line, but we're actually using the tangent approach here. And this is considered to be the best approach for calculating this. And this is particularly relevant in cases where you have these sort of long, broad T waves. And then you should be using the preceding RR interval when you're making the calculation. All right. So next question is, which lead should you measure it in? All right. Great. So I would say when I asked around and tried to look into this, all of these came up as reasonable answers. I think some combination of D and E are very reasonable approaches. There isn't really one particular best lead, but you should clearly be doing it in somewhere where it's most easy for you to discern the wave morphology and calculate it. And then in particular, if one appears to have a longer QT, that would be reasonable, a reasonable place to start. But we'll talk about a couple of scenarios that can be challenging. So the first is the setting of the wide QRS. And by definition, a wide QRS is going to lead to an increase in your QT interval, though this is not thought to be clinically significant in terms of increasing the risk for adverse clinical outcomes associated with a prolonged QT interval in particular. In these cases, some would advocate for the use of the JT interval, as you can see here, which is calculated in the same way, like a corrected JT interval you would calculate similar to a corrected QT interval. And the J point is where the QRS ends and the ST segment begins. In these cases, a reasonable cutoff for a normal JT interval would be less than 330 milliseconds. I personally don't really like having to remember more numbers. So I think another reasonable approach, and one advocated for by my mentor for this talk, Dr. Chatterjee, was to subtract the amount that the QRS is actually prolonged by. So say you have a bundle branch block and the QRS is 150 milliseconds, subtract 30 from that. So it's now 120 or normal. And then subtract that 30 from the QT interval, then use that new QT interval in your QTC calculation. So essentially normalize your QRS and then incorporate that into your QT. In the case of an irregular rhythm, there's a couple of different approaches to take here. For one, I would say that you should definitely not trust a computer calculation of a QTC in the setting of something like atrial fibrillation. The most thorough approach you could take would be to measure the QTC interval for 10 successive beats, so a full rhythm strip, and then average those. Realistically, though, it may be easier to just measure and calculate the QTC interval for the QT intervals immediately following both the longest and the shortest RR intervals, and then average those two. In the setting of a paced rhythm, I would say that this is perhaps one of the most complicated topics. And in this case, I would advocate that this is a case where if you have clinical concern and you're trying to make important decisions, you may consider actually enlisting the help of a cardiologist. The reality is that in many cases, you will have these patients have cardiologists by the fact that they have a pacemaker. And so you can often incorporate or get their help. And I would just say there's a number of different formulas and calculations that can be used for this that just was a little bit beyond the scope of what I was hoping to discuss here. And while none of us would ever advocate practicing this way, I do think it's important to remember that many people with pacemakers also have ICDs. So the relative risk for a prolonged QT interval is slightly different in that case because they inherently come with some security or some kind of security mechanism. Which is, of course, not to say we should be intentionally prolonging everybody's QT interval, but because this is a more challenging clinical scenario, it can be harder for us to get a clear answer as to whether or not the prolongation of their QT interval is meaningful. All right. And then the U wave is another challenging situation that sometimes comes up. And I would say there's not a lot of data as to the clinical significance of the U wave. Some people advocate that if you have a clearly distinct U wave from the T wave, and it's much smaller, many cardiologists would say that it shouldn't be included in the QT interval calculation. However, if it's a larger U wave or if it's sort of fused with the T wave, then some would incorporate that into the QT interval, though there's not really any evidence to suggest whether or not this is clinically meaningful. All right, another spot to review here. So measuring the QT interval is clearly inconsistent and challenging. The computer can be helpful. There are a number of different computer algorithms. None has been shown to be universally accurate, though. So I think it's always important that when in doubt, you measure it yourself. You should use the tangent approach to calculate the end of the T wave, and then you should alter your approach accordingly based on wide QRSs, irregular rhythms, pacing, and U waves. Pause one more time here for questions. We will jump into the actual namesake, so long QT syndrome. So long QT syndrome classically has been divided into congenital and acquired. However, I would say that there is some belief that this represents an artificial dichotomy. So congenital long QT syndrome represents all those individuals who have an identified genetic channelopathy. But those with acquired long QT syndrome who do go on to develop life-threatening arrhythmias plausibly carry some form of genetic predisposition that we just haven't yet identified. Within the genetic form or the congenital long QT syndrome, there are at least 13 distinct genotypes and counting, though types 1 through 3 are the most common and well described. There are also two classic phenotypes that are differentiated by the presence or absence of congenital deafness. Congenital long QT is also not a monolith. These are clinically distinct entities. So these graphs or these charts here demonstrate what the most common trigger for an arrhythmia is based on genotype. And as you can see in long QT syndrome type 1, it is most common that the arrhythmia is triggered in the setting of exercise, whereas in types 2 and 3, we see that the arrhythmia most commonly occurs in the setting of sleep. Similarly, diagnosing long QT syndrome is really challenging because perhaps it is such a unique entity and there are so many things that go into the different presentations. But this was one study that looked for diagnostic concordance in a referral population to a long QT syndrome specialty center. And it showed that only about 40% of, or rather that 40% of patients referred with a diagnosis of long QT syndrome did not in fact have it. So all that said, and then Becca, by the way, I see your question and I will come back to that, okay? So when should we be suspecting long QT syndrome in individuals? And I would say that these are things that you commonly think of in patients who present with possible cardiac syncope, sudden cardiac death, whether, of course, personally, but then a family history of unexplained car accidents or drownings. All of these things should raise your suspicion for occult arrhythmias, one of which could be long QT syndrome. There, of course, anyone who has an abnormally prolonged QTC in the absence of secondary causes should prompt some consideration for long QT syndrome. There aren't clear guidelines for this, but there is one approach that I have outlined here that is probably most relevant for use in sort of an ambulatory setting in patients who are otherwise healthy, because as we are all probably pretty familiar with, it's rare to see somebody with a normal QT interval in the hospital. So you suspect long QT syndrome, and what should you do next? The first thing is obviously a thorough evaluation for causes of acquired long QT. And these are things that we all are pretty good at doing at baseline. So evaluating the medication list, checking electrolytes, then thinking about things like thyroid disorders, starvation and anorexia, which have been shown to prolong the QT interval, and then a prior history of myocardial ischemia. It's also important to take an extensive personal and then multi-generational family history. And again, you're looking for things like cardiac, or not just cardiac disease, but arrhythmias, arrhythmia syndromes, syncope, sudden cardiac death, car accidents, drownings, etc. And then a resting 12-lead EKG. After that, I think that depending on your level of suspicion, probably the next step would be referral to either a cardiologist or electrophysiologist. There is a tool called the Schwartz score, illustrated here, which can help guide your degree of concern. It does include some unique EKG findings that I was not going to talk about in great detail here, but it could be one thing that you use to help risk stratify your patients and determine how quickly they should or should not be referred for specialty evaluation. But as you can see, this incorporates the electrocardiographic findings, the clinical history that we've already talked about, and then any family history to determine their risk of potentially having an underlying congenital long QT syndrome. The most common etiologies, obviously, for acquired long QT syndrome are things that we're all pretty familiar with and we've started to discuss already. So medications, electrolyte abnormalities, hypothyroidism in particular, and myocardial ischemia. New for me was I didn't realize that hypothermia and then starvation are both associated with prolongation of the QT interval. So these are other things to interrogate. And I thought this was particularly interesting, this article in the New England Journal about a decade ago that said in the preceding decade, the single most common cause of withdrawal or restriction of the use of new medications was QT interval prolongation. And they highlighted 9 structurally unrelated medications marketed in the US for non-cardiovascular indications that had to be removed from the market for this toxicity. So this is probably the most frustrating part of our practice. And the reason that I was sort of inspired to do this talk is because medications and QT interval prolongation are just very frustrating on a day-to-day basis. We're all pretty familiar with the most common medications that do this. So obviously our antiemetics, our antidepressants, antibiotics and antifungals, the antipsychotics, and then in particular methadone. These are probably the most common ones that we interact with on a day-to-day basis. I will say that among medications, those with the clear highest risk of QT interval prolongation are unsurprisingly the antiarrhythmics. But of course, this is not so much a side effect as it is a marker of their efficacy and mechanism of action. In terms of electrolytes, it's pretty much any low electrolyte will do it. These 3 are the ones that we should be thinking of most commonly. And I think we're all pretty good about doing this. There are some data that actually query whether or not the hypokalemia is truly prolonging the QT interval, or if it's just increasing the risk of torsades when the QT interval was already prolonged from other causes. And the thinking there is that we know that hypokalemia can cause the induction of a prominent U wave, which might make the QT interval just appear artificially long. In any case, it's always right to replete electrolytes in the setting of like hypokalemia or hypomagnesemia and a prolonged QT interval. All right. So like we talked about here, long QT syndrome is important to recognize. And I think it's something that we often see and don't necessarily add to our problem list, but it is something we should be thinking about in patients because it is abnormal and needs to be addressed. We should remember the family history and then consider any unexplained syncope or sudden cardiac death or suspicious sounding death that could be cardiac. And then remember, of course, that medications and electrolyte abnormalities are our most common causes of acquired long QT syndrome. Just going to pause one more time before the last section here. Becca, with response to your question, I would say that it really does vary. It can be quite wrong, and it really just depends on what the underlying EKG looks like. So again, if you eyeball the EKG and it looks like a relatively normal EKG, the computer is more likely to be right. But if there's these things that we've discussed that are abnormal, like irregular rhythms or other abnormalities in morphology of the waves, I think it's not wrong to at least calculate, say, 1 beats QT interval and kind of get a sense as to, is that about right? Obviously, we're busy, but I will say putting your patient into torsades is only going to make your night busier. So, cool. So wrapping up here, I really liked this. And sorry, I meant to put the source on the page here, but this was from an article I found, and I am going to read it because I think it kind of wraps up really nicely what we're talking about here. So the precise relationship between the prolongation of cardiac repolarization and risk for serious ventricular arrhythmias remains unresolved. The clinical measurement of repolarization, the QTC, is a highly variable parameter that does not closely correlate with risk for sudden cardiac death, perhaps because prolongation may occur by a number of different mechanisms of variable proarrhythmic potential. However, existing data suggest that the magnitude of QTC prolongation and the characteristics of the population, in particular the presence of heart disease, are the most important determinants of risk for torsades and sudden death. So, how should we be managing this? And I think these are the principles that I wanted to highlight here, and we'll talk a little bit more about them as we wrap up. So the first thing is, I think maintaining a high index of suspicion is really important. Remember that the prolonged QT is actually a problem. It's not just an inconvenience. You should look at the EKG. You should consider manually calculating it, and you should review priors because history does tend to repeat itself. We should obviously correct our electrolytes and review our medication list, deprescribing where possible. Know that reducing doses and then changing your route and speed of administration does make a difference. So lower doses, oral administration, and more slowly is going to result in less QT prolongation. Also think about thoughtful monitoring. So when should we use telemetry or serial EKGs? And then counseling patients is going to be relevant here. So I think this is sort of the four-pronged approach I would recommend, which includes stratifying risk, minimizing it where possible, and then our monitoring and informed consent. On the topic of risk stratification, I will say this is really hard. Practically speaking, for internists, this is often just a question of medication management. So most studies that look at the degree of QT prolongation rather than the absolute or relative risk of torsades. If you were to look up any kind of medication that has data suggesting that prolongs the QT, I will tell you that you are going to have a hard time figuring out what the actual relative risk of developing a malignant arrhythmia is. It will just tell you it prolongs the QT interval. There are a lot of medications that actually have a really strong association with prolonging the QT interval, but do not have a strong association with torsades. One that comes to mind that we use all the time is amiodarone, which has a relatively low risk of development of torsades despite its significant effect on the QT interval. There are a few tools, though, that I think are useful to know about. So the first is this risk stratification tool, and this is the Tisdale risk score for QT prolongation, which is available on MD Calc. And it was developed and validated in a patient population who was admitted to CCUs, so coronary care units. And it is somewhat useful, particularly in those who have underlying heart disease. As you can see, it asks questions about age. It does ask about sex, which I think here is relevant for that sex hormone balance that we discussed before. Then diuretic use, what their admission QT interval was, and then what they've been admitted for. This is actually a tool that I found in researching this talk that I think is particularly interesting. And this is a nomogram that was developed in one study that examined the risk of torsades, plotting the uncorrected QT interval with the heart rate. And as you can see, those who fell below this nomogram line did not develop torsades, whereas those who were above it did, indicating that there is some relationship between heart rate and QT interval. So there's a relatively increased risk of bradycardia and elevated or prolonged QT interval, meaning that those are the patients who are at highest risk for torsades. And I think this is a really nice tool that you could use that spares you from having to calculate corrected intervals. So I've started to look at this in my own practice, and I've found it to be pretty helpful. Another tool to just look for medications in particular, this is a website and an app called Credible Meds, and its sole purpose is to create an encyclopedia of medications that prolong the QT interval. You could obviously, and probably more easily, can talk with your pharmacist during the day or use things like UpToDate, which are totally reasonable. But this one I found to be the most comprehensive list of this, and it will actually link you to the particular studies that have shown QT prolongation as a side effect. Unfortunately, again, it doesn't really give you a sense of the degree of prolongation or the absolute risk of developing arrhythmias, but it is one nice resource. When it comes to monitoring, I think this is a particularly useful thing to think about, and that is to not forget your pharmacology. So there's two different approaches here. The first is to think about single doses and how a single dose of a medication may increase the QT interval. And in that case, you're particularly interested in the peak drug concentration. So if you look up what when the peak drug concentration of a medication you administer will be. You could potentially get an EKG at that time to see how much the QT interval has been prolonged. And then in the setting of a more chronic medication you're planning to initiate, you want to think about steady state concentrations, which generally happen about 5 half-lives into the dosing schedule. And you could consider checking an EKG at that time to see what the QT interval is settling out to be. In terms of telemetry, fortunately, there are actually guidelines here. So the American Heart Association has a guideline recommendation for when we should be monitoring telemetry in the setting of concerns about QT interval. And there are a couple of different recommendations here. So the first is drug initiation of antiarrhythmics is an indication to monitor on telemetry, as well as other medications that are known to prolong the QT interval, but only in the setting of somebody who has an underlying prolonged QT interval or other risk factors. So just starting a medication alone is not an indication. They have to have some other risk factor or a known prolonged QTC. Similarly, in the cases of drug overdose, particularly if the drug is known to prolong the QT interval or if we don't know what the drug is. In congenital long QT syndrome, they recommend monitoring in the setting of ongoing arrhythmias, obviously, or if there's medically or metabolically induced additional prolongation of the underlying QT interval. So not just because they have a baseline prolongation, but if something else is deranged causing prolongation. Clearly, the one we're all very familiar with is electrolyte abnormalities ongoing. So we commonly do this in our patients who are being diuresed and have frequent electrolyte abnormalities. And then additionally, there's a recommendation in targeted temperature management, which of course, these patients are all in the ICU and getting telemetry monitoring anyway. So we'll wrap up again. We're returning to our case. So this was, again, our patient who had a QTC of about 500. They're wondering about an order for ondansetron. And we saw a number of different approaches here, and I don't think any of them are particularly wrong. This is one recommendation that I found. This is actually somewhat conservative, I think, compared to how most of us would practice. But they recommend avoiding QT prolonging medications in those who are over a threshold of 470. I think most of us feel more comfortable or feel pretty comfortable up to about 500, which is, as far as I can tell, based on the available evidence, not unreasonable. However, if you are trying to avoid QT prolonging medications in the setting of nausea, which is, I feel, one of the most common situations we run into, you could consider some of those in that middle box there. So diphenhydramine or dronabinol are good options. I don't think we have the last one. Actually, I don't even know if we have dronabinol, to be honest, but those are things you could consider. In addition to, like we discussed, there is evidence for aromatherapy with isopropyl alcohol and some of those other non-pharmacologic mechanisms. We do have it. Great. When I asked Dr. Chatterjee, who helped me make this talk, this was a direct quote from him, which is that he felt that the transposition of risk in genetic long QT is indeed helpful. And while it's not perfect, it's clear that the data shows that risk for malignant arrhythmias is incrementally increased beyond about 500 milliseconds and even more so over 550. And so he had reservations in prescribing QT prolonging medications for anyone whose baseline was greater than 500. I think one other approach we could all consider, and one we're pretty familiar with, is that of informed consent and constant evaluation of risk benefit. It's something we're all pretty used to doing in the setting of initiating anticoagulation. And I think that it's not unreasonable here. We may see poor outcomes associated with prolongation of the QT interval, but we just don't have enough data to know when that's true or when that will happen. Similar to how we weigh risk and benefit of anticoagulating patients. So I think sharing our understanding of what the risks are with patients and allowing them to be agents in their own healthcare. Obviously, things like nausea are very unpleasant, and in certain situations, it may be very reasonable to treat them for these more aggressively, even if it comes with some risk. So with that said, I will wrap up here. Remember that our QT interval is imperfect. It is pretty much the best thing we have right now, though. There are a couple of resources that we talked about here that can help you risk stratify. And then just remember how we think about monitoring. You can use your knowledge of pharmacokinetics, the telemetry guidelines, and then think about risk and benefit in certain patients. And with that, I will wrap up. And then Kim, I don't, though I could certainly put together one with those slides I had. Yeah, I can do that.
Awesome. Thanks so much, David. That was great. To any of the interns still here, please go ahead and join Intern Core Conference.